Thank you very much. So I'm Fadi Haddad from the leukemia department at MD Anderson Cancer Center in Houston, Texas. And I will be talking today about our phase 2 trial of mini-hyper-CVD in combination with venetoclax for patients with relapsed refractory acute lymphoblastic leukemia. So we know that venetoclax is an oral BCL2 inhibitor that has activity across a wide variety of hematologic malignancies. And there have been preclinical studies that showed that venetoclax had a significant synergy when combined with chemotherapy, along with promising clinical activity in patients with relapsed or refractory acute lymphoblastic leukemia. And that's why we hypothesized that combining venetoclax with low-intensity chemotherapy, in our case, the mini-hyper-CVD regimen, could further improve the outcomes in this setting. So what we did is we treated patients with relapsed or refractory B-cell ALL or T-cell ALL with this combination. So first they received chemotherapy, the mini-hyper-CVD, which is an attenuated form of the original hyper-CVAD regimen, where methotrexate and cytarabine are given for up to 8 cycles, along with cyclophosphamide, dexamethasone. All of those are given at dose reduction with no anthracycline. Venetoclax is given on this protocol at a dose of 400 milligrams per day during cycle 1 from days 1 to 14. And from cycle 2 to cycle 8, it is given at 400 milligrams per day from days 1 to 7. For patients who have T-cell ALL, those patients receive 2 additional cycles of nelarabine and PEG asparaginase after cycle 4. So this is during the consolidation phase without venetoclax. So we don't give venetoclax when nelarabine and PEG asparaginase are given, as well as 2 cycles of nelarabine and asparaginase during the maintenance phase, which is beyond cycle 8. And all the patients who responded went to receive maintenance therapy with vincristine, prednisone, and venetoclax for up to 2 years. So the maintenance cycles were for 1 month each, and venetoclax were given for 2 weeks during each of those months. So how many patients we had? So we had in total 23 patients so far. Median age was 45 years. Most of the patients, 80%, had B-cell ALL. 57% of the patients were in salvage 2 and beyond. 43% were in salvage 1. The median prior number of therapies was 2, and some patients received up to 6 prior lines of therapy. And patients who have particularly B-cell ALL, 89%, which is almost 90% of the patients, had prior blinatumomab, and 40% had the prior inotuzumab. 50% of the patients had even received the prior stem cell transplantation. And in this cohort, about the quarter of the patients had poor risk cytogenetics, so either hypodiploidy, near triploidy, complex karyotype, or translocation 411. The third of the patient as well had TP53 mutation. So those are all poor risk features of this disease. So among those 23 patients, we had 1 patient who was included in remission. So we have 22 patients who were evaluable for response. Of those 22, we had overall 12 patients who responded to therapy. 9 of them achieved a complete remission with full count recovery. If we look at the overall response rate after cycle 1 only, 67% of the patients responded. This regimen was overall safe, well tolerated. We didn't have much of grade 3 adverse events. If we look at the rates of myelosuppression, the median time to platelet recovery after cycle 1 was 27 days, and after cycle 2 and beyond, it was 25 days. And the median time to neutrophil recovery was 21 days after cycle 1 and 15 days after cycle 2 and beyond. So let's see now how those patients responded. So among those 23 patients included, 10 of them did not respond. They were refractory to treatment. 13 of the patients, including the one who was enrolled in remission, so those 13 patients responded. 2 of those patients died while in remission. 6 of the patients, unfortunately, relapsed. And 5 of the patients were able to be bridged to an allogeneic stem cell transplantation. Unfortunately, again, 4 of those patients relapsed. So how does the survival look of this cohort? So the median overall survival was 8.1 months. So here we still have a short follow-up. The median follow-up is 26 months. The 1-year overall survival was 33%. But if we separate patients according to cytogenetics, we can see that patients who have adverse cytogenetics did poorly and had worse outcomes compared to patients who did not have worse cytogenetics. The median overall survival of patients with bad risk disease was 6 months compared to 12 months in the remaining patients. And the 1-year overall survival was 17% compared to 44%. There was no early deaths observed at 1 month, and the 60-day mortality rate was 13%. So what can we conclude from all those results? So we can conclude that in patients with relapsed refractory acute lymphoblastic leukemia, the combination of the slow intensity chemotherapy mini-hyper-CVD with venetoclax showed clinical efficacy, showed a safety profile. The response rate was 67%. But again, this is not a definitive therapy. I would consider this therapy a bridge toward stem cell transplantation or another type of therapy. Thank you very much.